Good morning. I want to welcome you to this multidisciplinary session. This is going to be on the advances in the multidisciplinary medical management of hepatocellular carcinoma, current and emerging options. And this program is supported by an educational grant by Genentech, and really want to thank them for their support. We have a distinguished panel of faculty here. My name is Ripal Gandhi. I'm an interventional radiologist at the Miami Cardiac and Vascular Institute and the Miami Cancer Institute. We have Maria Hernandez, who is a gastroenterologist and hepatologist at the Miami Cancer Institute and Gastro Health. Dr. Ramon Jimenez is a hepatobiliary surgeon at the Miami Cancer Institute. Dr. Ed Kim, interventional radiologist at Mount Sinai. And Dr. Michael Morse, who's a medical oncologist at Duke. These are our disclosures. And again, I wanted to thank Genentech for this educational grant. These are our learning objectives. We're really, our goal here is to, really talk about the different advances in systemic therapy as well as local regional therapies for hepatocellular carcinoma, and to really present this in a multidisciplinary fashion. And I'm going to introduce our first speaker, Dr. Michael Morse. He's going to be talking about advances in systemic therapy for hepatocellular carcinoma.
Well, thank you, and thank you for the opportunity to speak to your group here today. As a medical oncologist, when I started my practice a bit more than 25 years ago, there wasn't really a role for me with hepatocellular carcinoma. The surgeons never sent the patients. The interventional radiologists also didn't send the patients. And so it was kind of lonely. I did mostly other GI oncology work. But obviously over the years, we've developed a number of therapies, and now we have powerful combinations that I'll be talking about that are now starting to integrate with also what you do from an interventional standpoint. So here are my disclosures. And you'll hear me talk a lot about stage of patients today. To a medical oncologist, we often use very standard staging systems, the HACC TNM system. But that doesn't work that well in hepatocellular carcinoma, mainly because while it takes into account the extent of disease, it doesn't really take into account the really critical features of the underlying liver function and performance status. And there are perhaps more than 20 different staging systems that are used worldwide, but all are trying to get at this issue of how do you understand the prognosis for patients, and how do you choose therapy based on the fact that many patients with hepatocellular carcinoma have underlying cirrhosis, the majority do, and that affects their liver function, affects the options for management, whether it's surgery, interventional, or medical management. Or some patients, their survival from their cirrhosis is so short that contemplating other therapies just doesn't seem to make sense. So one that's now used in the majority of clinical trials, and I use it in my clinic certainly, is the BCLC system. This one, the Barcelona Clinic liver cancer system, takes into account, as you can see here, extensive disease, single lesions, multiple lesions, multinodular, portal vein invasion, extrahepatic spread. It also takes into account liver function using the Child's classification, and also performance status. And it does a couple of nice things. One is that it gives you certainly a way of separating patients out by prognosis. It also, and I don't have it demonstrated in this slide, but it does move you down certain pathways for management. Now, all of you are part of multidisciplinary boards of some sort, I assume, and therefore you may have your own management directions for patients, but in general, the different stages feed into certain management. Earlier stages, of course, surgery might be an option, or ablation. Then you get into the local regional therapies, embolization, Y90 radioembolization, then into the systemic therapies. And unfortunately, no therapy if you have very poor liver function. But there is really a blending that's starting to happen now. And while I would have said originally medical oncology was squarely in the stage C patients, extrahepatic spread, portal vein invasion, some decline in liver function perhaps, we're now looking at therapies that have a role in some patients that are BCLC-B, the multinodular. And of course, I know you apply some of your therapies to people that would be considered BCLC-C as well, portal vein invasion. And we'll talk a little bit about combination therapy later on. This is the obligate slide on everything we know about the biology of hepatocellular carcinoma, and it's intentionally dense. Suffice it to say that we don't really understand. Obviously, the more you pack into a slide means the less you understand about it. And it means that there's a lot we do and don't understand about the biology of hepatocellular carcinoma. For example, we do have subgroups, but we don't really talk about them clinically, unlike breast cancer, where you talk about certain subgroups of patients. We don't really do that in hepatocellular carcinoma so much, other than perhaps the stage. We also don't routinely use biomarkers. You could argue that AFP is a biomarker in one scenario, which I'll briefly discuss later. But by and large, this is not a malignancy where, while we can do next-generation sequencing and look for potential targets, it's not required and not usually part of the initial management of these patients. Suffice to say, just like many other malignancies, though, these tumors do, of course, depend on a blood supply. You know that by your management strategies. And that has driven a lot of the therapy. So any therapy that affects the ability of blood vessels to grow or sustain a tumor many of those have had activity in hepatocellular carcinoma. We'll discuss some of those afterwards. We also now know that the immune system can recognize some hepatocellular carcinomas and lead to their destruction. And there are combinations of these therapies, but there are many other pathways that would be nice if we could target. Wnt beta-catenin, for example, which is found in many cancers, colon cancer, for example. We really don't know how to target that yet. There's a lot of protein-protein interactions, and they're a lot more difficult to, quote, drug. Well, where did we start out with? Well, we really started out with me being lonely in my clinic, but then we started getting into systemic chemotherapy. And while there is some activity for it, we can use Folfox, for example, to treat some patients. The reality is that it's too toxic for most hepatocellular patients, and the efficacy is modest, and you have to continue people on therapies that are often not feasible to continue long term. So although they were out there, we were really looking for something different. And playing off of this idea that there is proangiogenic activity that leads to high infiltration of vasculature and highly vascularized tumors, the idea was, how can we target that medically? And we, of course, were developing these drugs in many other malignancies, the tyrosine kinase inhibitors for vascular endothelial growth factor receptor, as well as the antibodies that bind VEGF, the VEGF and the VEGF receptor being the predominant driver of this particular pathway, although there are a number of other growth factors for the vasculature. So the first drug that made it through the gauntlet in a randomized clinical trial that was against placebo in a large number of patients is called the SHARP trial, and it was sorafenib. Now, I mainly show this out of historical interest, although the drug is still being used, but it gives you a benchmark. If you look at the overall survival for patients enrolled in this study, this is first-line advanced HCC, you can see 10.7 months versus 7.9 months for placebo. There was also a very, very low response rate, but there was one there. Now, this study was also replicated in an Asian population. And you can see there, the patients enrolling in the Asia-Pacific trial had more advanced disease, much bulkier disease. And their survivals were 6.5 versus 4.2 months. So it gives you a range about how this drug has some impact compared to no systemic therapy, but very modest, and those were our benchmarks. It took a number of years for another drug to show even non-inferiority to sorafenib. There were many other attempts with other tyrosine kinase inhibitors to show superiority to sorafenib, and they all failed. So finally, in a clinical trial, the REFLECT trial with lenvatinib, which has a lot of similar functions to sorafenib, being a VEGF receptor tyrosine kinase inhibitor, as well as a number of other pathways, that it was compared in a study of advanced HCC, but now the idea was non-inferiority for overall survival, and they also looked at progression-free survival and response rate. And here, now you can see the overall survival, first of all, for sorafenib has improved. Now, this may be a reflection of subsequent therapy for these patients, not necessarily that sorafenib was getting better or we were better able to manage patients, although we hope that was the case. But you can see here now the benchmark has moved to 12.3-month median survival for sorafenib. But Lenvatinib was non-inferior at 13.6 months, but that met its endpoint. Now, for progression-free survival, it was double, definitely superior, and response rate was also superior. Now, this gets into the concept of how you measure response rate. There's RECIST, the standard measure, the longest dimensions of the measurable lesions, take the sum of that, give somebody therapy, repeat. Does the cancer shrink by at least 30%? That's a response. Does it increase by more than 20%? That's progression of disease. In the middle is stable disease. And you hope you get a complete remission, although they're highly unlikely to see with a tyrosine kinase inhibitor. Now, using modified RECIST, you probably do this intuitively. You're looking at the vascularized area, the area that the contrast gives you the hyperenhancement, and you're looking at those dimensions. Again, adding them up, give a therapy, repeat, and again, determine whether there's a response based on that. You can see with modified RECIST, now we're seeing higher response rates. But it's still the fact that these are fairly modest gains, and they come with some toxicity. So the tyrosine kinase inhibitors have two broad types of toxicities. There's the vascular types of toxicities because they inhibit vascular flow to tumors, and so there can be heart attacks and strokes and hypertension and proteinuria. But we also have, because they target some other pathways, you also get, I'm going to call them TKI type toxicities that you see across the class of drugs that have tyrosine kinase inhibition. You can get what we call PPE, palmar-plantar erythrodysesthesia or hand-foot syndrome. You can get oral lesions and diarrhea and fatigue. And so all of these were observed in the study. And some were more common with lenvatinib. It is a more potent VEGF receptor TKI than sorafenib. Some of them were a little bit more common with sorafenib, like the hand-foot syndrome, a little bit more in the TKI direction. Well, that's where we were. Those are the drugs we've had until very recently. Other attempts had been negative. But it was observed in other malignancies, and I've done a lot of laboratory-based work as well on immune therapies, and we and others have demonstrated that the vascular endothelial growth factor and some other growth factors for vasculature also seem to have a negative effect on the immune system. VEGF, for example, affects dendritic cell maturation. Dendritic cells are the sentinels. They pick up antigen, process it, and present it to T cells to activate T cells that can then hopefully traffic to and destroy tumors. Well, if VEGF has an immunosuppressive effect, perhaps inhibiting the VEGF pathway would also have some effects on ameliorating that defect in immune response. And indeed, in preclinical trials, it does. So then the observations were around, well, what if we combine an anti-VEGF strategy with an immune therapy as those were emerging in clinical trials? And preclinical data and clinical trial data suggested they do synergize. There is an enhancement of the immune response against cancers when you use strategies that target vascular endothelial growth factor. Data from other clinical scenarios, such as renal cell carcinoma, were already demonstrating proof of this. So therefore, a number of studies were initiated. This is the one that's led to an approval currently of a combination of one of the anti-PD1 or PD-L1 therapies. In this case, we're going to be talking about an anti-PD-L1 therapy, atezolizumab. So these therapies work by blocking the interaction of PD-1 on T cells with PD-L1 on either tumor cells or other infiltrating immune cells. This interaction leads to T cell dysfunction. So although there may be T cells within the tumor environment that could potentially destroy the tumor, in fact they can't, because when they bump up against a cancer cell or some other infiltrating immune cell that deploys PD-L1, the PD-1 on the T cells, which is an activation marker. If you activate a T cell, PD-1 is going to be upregulated. That interaction leads to T cell dysfunction and no more attack against the cancer. So in the IMbrave 150 trial, there's a combination of atezolizumab, the anti-PD-L1 antibody, with bevacizumab, an anti-VEGF antibody. And this was compared with sorafenib in advanced unresectable hepatocellular carcinoma. This is a worldwide study, a large study, randomized, all the features that you want to have to get a Category 1 indication. And there were co-primary endpoints, overall survival and progression-free survival. Kind of gutsy when you think about the previous data where, at best, there was non-inferiority over sorafenib. But here we had co-primary endpoints. And The baseline characteristics for the patients were as you would expect for a large study of HCC patients. They were well balanced. I do want to point out that this study did enroll some BCLC-B patients, those multinodular patients, but it was predominantly BCLC-C. You had to have child A liver function. Almost every clinical trial, pivotal trial, is using patients with child A liver function. I'll talk a little bit about child B later. And some patients had had prior local regional therapies as well. One thing I do want to point out is that you did have to have some evaluation for varices. That is, we know that patients with advanced hepatocellular carcinoma on the overlay of cirrhosis often have esophageal varices, and those could lead to increased risk of bleeding with an anti-VEGF strategy. So patients had to be evaluated within the last 6 months by local standard. It didn't require an endoscopy the week before. It was your local standard. And so about a quarter of patients did have esophageal varices when they entered, and about 10% had been previously treated for them. And here's the overall survival data. Like any other good medical oncology trial, it shows positivity. The curves separate early, they stay separated, and no matter how you look at the benefit, you can look at a median, for example. So we now have a new standard at 19.2 months median overall survival. You can see that sorafenib, again, that 12-month bar that we're now starting to hit with the drug. So statistically significant, meaningful overall survival benefit. You can also look at landmarks. There's clearly a better survival at 6 months and 12 months and so on. Progression-free survival was also improved. Again, curves separate, they stay separated. It's a meaningful benefit trying to keep the cancer from progressing in patients with advanced hepatocellular carcinoma. That means often better performance status maintenance. And indeed, there were metrics for evidence of patient benefit, clinical benefit, that were looked at in this study, and all of those metrics for patient well-being, all of those metrics were also in favor of the atezolizumab plus bevacizumab. Now, of course, we want to know, my patients want to know, is it going to shrink the cancer? Now we're starting to see response rates that are almost 30%, whether you use RECIST or modified RECIST, and there are complete remissions, about 10 to 11%, depending on whether you use RECIST or modified RECIST. This is really the first time we've seen complete remissions with medical therapy for HCC, and these can be fairly durable remissions as well. Of course, it also comes with toxicity. Now, you have an immune therapy. These immune therapies, broadly speaking, cause the itises, immune-related adverse events. You get, for example, you could have colitis or pneumonitis or even autoimmune hepatitis. Fortunately, they're infrequent, and in fact, most of the toxicity seen in this study was related to the bevacizumab, the anti-VEGF effect. It's more potent in some ways than targeting by TKI, therefore there was more hypertension, more proteinuria that was seen with the bevacizumab plus atezolizumab. But the TKI-like effects, the hand-foot syndrome, for example, those, of course, were worse with the sorafenib. So it's a very well-tolerated regimen. And you can see there that the grade 3-4 bleeding, some of which was variceal, but some was epistaxis or other types of bleeding, was fairly balanced between the two arms of the study, only slightly higher with the atezolizumab bevacizumab, which is very gratifying considering that, again, this is a vascular targeting therapy, and some of the patients did have esophageal varices. And the last thing I want to point out is the risk of autoimmune hepatitis, particularly severe grades, was very low. And what had been discovered earlier with immune therapies in HCC is that it doesn't matter what your underlying etiology of the disease is. In general, you do get a benefit from the therapy. And there was some concern initially that, well, if we give this to somebody with hepatitis, perhaps the immune response will lead to severe, reactivation of their underlying hepatitis. That does not occur. So these are very safe to give to patients with any type of underlying HCC. Now, in this study, again, it was child A patients. So now in medical oncology, we often use something called NCCN Guidelines. We're an NCCN institution. Many places have their own pathways. But suffice it to say, these are ways of managing malignancy that are generally agreed upon by experts. So you can see here now that atezolizumab plus bevacizumab is now the preferred category 1 regimen for advanced HCC in patients with Child-Pugh Class A liver function. Now, there are some other options. Sorafenib and lenvatinib have not gone away. They're still available, and for some patients, they are more appropriate. And single-agent immune therapy, although it has not shown an overall survival benefit, I'm going to get to that in a second, but up until very recently, they are still listed for patients where a single agent might be appropriate, and that's nivolumab, but in general, it's not going to be used. So the pros and cons, of a TKI versus an immune-based strategy. Well, the convenience of an oral therapy, lenvatinib and sorafenib are oral. The others, you have to come in and receive. Short half-life if there's toxicity. Bevacizumab has a 21-day half-life. An immune therapy would be contraindicated if you're going to have a transplant or you have severe autoimmune disease. That's not a problem with the TKIs. We don't have a lot of data for what to do after the immune therapies in the first line because this is a new concept. We have a lot of data about what to do, particularly after sorafenib in second line. And then the esophageal varices, hard to say, definitely a concern if you have the classic concerns with a varice like the red whale sign, for example, but with using bevacizumab. But the TKIs, a little unclear. They may be safer, probably not in those people with imminent complications of their varices. But the studies that looked at TKIs in general did not have the same rigorous requirement for evaluation of varices, and therefore probably had a higher rate of varices and yet didn't have more bleeding. So it suggests that the TKI-based strategies could be relevant for people where you're really worried about esophageal varices. Frankly, they should be managed before patients get any of these therapies. What about Child-Pugh Class B? Now, the Cs we often don't treat because their survival from cirrhosis is very short. But with Class B, that's like half of my patient population, and they weren't included in these studies. But we do have data. There is some data with lenvatinib and sorafenib showing they are tolerable. Survival for Child-Pugh B is shorter, no matter how you slice it, than Child-Pugh A patients. However, they do appear to be safe and probably have benefit. And single-agent nivolumab, one of the anti-PD1 antibodies, has also been evaluated in Child B patients and appears to be safe and have some activity. Now, where are we going in first line? Well, more combinations. So we had a combination of atezolizumab plus an anti-VEGF antibody. What about an anti-VEGF strategy that's TKI-based? Well, this is the COSMIC-312 trial. This one has only been reported in, say, press release. This randomized patients to cabozantinib plus atezolizumab, cabozantinib being an anti-VEGF TKI, as well as a variety of other targets, against sorafenib, and there was also a cabozantinib arm only. And the data we know from the press release is that the overall survival was not statistically improved by the combination. PFS did appear to be improved. So there's activity for this combination, and we're waiting to see the detailed data from the study. What about combined immune checkpoint? This is being done in a variety of cancers now, an anti-PD1 or anti-PD1 plus an anti-CTLA4, trying to get two different parts of the immune system engaged. And so there was previous data from using durvalumab, an anti-PD1 antibody, with tremelimumab, an anti-CTLA4 antibody, in subsets of HCC patients. And here you can see that the survival was fairly respectable here compared to what we had been seeing. And this included some patients that had been previously treated. So based on that, the Himalaya trial was started. This one just reported out a week ago, so all we know, again, is press release data. The durvalumab plus tremelimumab with front-loading tremelimumab did show an overall survival benefit compared to sorafenib, and the single-agent durvalumab was non-inferior to the sorafenib for overall survival. That's all we know right now from the study. But it does give us the possibility that we'll be using combined immune checkpoint now without any VEGF targeting in the strategy. So it brings up a lot of interesting possibilities about which patients this might be appropriate for. In any event, we really need to see the data. And then there are other TKI combinations with anti-PD1 or anti-PD-L1. This is lenvatinib plus pembrolizumab being anti-PD1. And here you can see response rates that certainly rival those that we reported out from the IMbrave 150 trial. And so there is the Leapo2 trial. This one is waiting to report out. This is lenvatinib pembrolizumab versus lenvatinib. And I will point out there's probably about 20 other studies that include a variety of anti-PD1s going on around the world, anti-PD1s and PD-L1s. There is another anti-PD1 plus anti-VEGF bevacizumab biosimilar. So sintilimab plus a bevacizumab biosimilar in the ORIENT trial that did show a benefit overall survival compared to sorafenib being developed in China. What about second line? Well, the first point is get patients to second line, get them the benefits of the therapy. If you look at the overall survival benefits for people who have had second line therapy, now we're looking at 26 months overall survival. Again, that may explain why sorafenib has been looking better and better over time, because many of those patients now have had the benefit of getting second line therapy as well. NCCN Guidelines list some TKIs, they list some immune checkpoints, they list an anti-VEGF receptor antibody and ramucirumab. They also list immune therapies, and there are a variety of ways you can really play second line now. The reality is that the TKIs do have different mechanisms of action. They all have the VEGF receptor in common, but some have some direct targeting of pathways that would be found in the cancer cell. Some are targeting other vascular pathways. So you really have some choice based on them. Just briefly, without going through every clinical trial, these are the ones that have shown benefit. So we know that regorafenib compared to placebo. Now, let me point out, all these studies were done in people who had sorafenib, either progressed on sorafenib, intolerant to sorafenib. Some studies required people to be tolerant to sorafenib. Some had massive liver involvement allowed, some didn't allow it. Slight differences between the trials, but in general they were done in a sorafenib pretreated population. And they all showed benefit compared to placebo, at least the TKIs, so regorafenib and cabozantinib. Ramucirumab, it took a study of patients with high AFP to show a survival benefit compared to placebo, but that was successful. That's the VEGF receptor 2 antibody. And then the immune therapies, now nivolumab was tested by itself as a single agent. It was tested along with ipilimumab, a combined strategy by itself, but showed very high survival, and therefore it is still listed in NCCN Guidelines. And then pembrolizumab, the first trial against placebo was actually negative. Although it looked positive, it didn't actually meet its endpoint. There's just been a recent Korean study that did show it met its endpoint. But again, all of these were after sorafenib, and that's the challenge we're dealing with. What do we do now that a lot of people are getting atezolizumab plus bevacizumab? They're already getting an anti-VEGF strategy. They're already getting an immune strategy. Well, we have very little data. This is retrospective data and just gives us a flavor of what happens if you give a TKI after you get atezolizumab, bevacizumab. And, you know, there looks like there might be some activity, but we'll have to see how this plays out eventually. There are studies formally looking at it. The last negative 2 minutes I have, I'm going to just talk about combinations. So what about people that have resections? The BCLC-A patients predominantly. Well, there is a lot of interest in combining particularly the immune therapies. Unfortunately, TKI did not work here. The STORM trial with sorafenib did not show a benefit in resected or ablated patients as an adjuvant. A hint of where we may be going, there was data from the NAVALVE trial that showed a 1-year relapse-free survival with the use of nivolumab after resection or radiofrequency ablation of 75% and 26 months relapse-free survival. So that might be a benchmark for what these pivotal trials might show. And again, there are a number of these studies. Now, what about combinations with transarterial chemoembolization? A number of studies also going on with immune therapies or immune therapies plus targeted strategies. And, you know, some preliminary data, this was a very small study. It was very hard to find studies that have reported out with these combinations so far. But you can see here in a very small group of patients, perhaps some durable responses, longer than you might quote patients who are just getting transarterial chemoembolization alone, but still very little data. But a number of studies going on that will provide some information. So in summary, systemic therapy now does have a role in HCC. In first line and second line, there's even data in some third line patients. So we should not be nihilistic, treat patients, try to get them to multiple lines of therapy. Most of the data is with Child-Pugh A liver function. Child-Pugh B patients, it does appear to be safe to give these therapies. There may be benefits in them as well. First-line standard for the majority of patients right now is going to be atezolizumab plus bevacizumab, but some people may not be candidates for it, and you do have the TKIs that are still available, and there are a number of combinations that are ongoing. It looks like dual checkpoint has activity. We're waiting for readouts of also more TKI plus anti-PD1 or PD-L1. Second line, it's probably going to be a TKI right now, if that's what I have to treat a patient with, but we're waiting for other combination data, particularly immune therapy after prior immune therapy, and adjuvant therapies are under development. Thank you.
It was a great talk, a really nice overview of all the systemic therapies for HCC. I think, most of the advances that we've seen in HCC in the last few years have clearly been with systemic therapy. A lot of great trials that are going on. I think for the remaining time, we're going to go through some cases and, try to get a multidisciplinary discussion here and understanding on how to treat some of these patients. These are my disclosures. So this is a 76-year-old gentleman with a history of atrial fibrillation, has NASH, hyperlipidemia, and is obese, presents with a solitary mass in the liver. Has preserved liver function, good performance status, AFP is 7, and here are the FibroScan results as well as, I'll show you the imaging in a second. Maybe we'll start with Dr. Hernandez. In a patient like this, is this a patient that should have surveillance for HCC?
Yes, for sure. We have seen with an increased incidence of patients who are not cirrhotic and develop HCC, and that happens mostly in patients with metabolic syndrome and NASH. So the fact that he's F3 on FibroScan, then it should warrant HCC surveillance.
Yeah, can you tell us, tell us a little bit more? Tell us about how you interpret these FibroScan results.
Yeah. So this is a non-diagnostic test, but it basically suggests two things: the degree of hepatic steatosis and the fibrosis of the liver. So, and we normally just grade the hepatic steatosis from S1 to S3. S1 meaning that there's less than 30% steatosis within the liver, and S3 there's more than 60% steatosis within the liver. So patients with CAPS above 290, or, as it says there, are considered as having severe hepatic steatosis. When it comes to median liver stiffness, it basically means that the CAP measures the resistance of the hepatic parenchyma to the passage of the ultrasound wave. So the more resistance, the more obviously presence of fibrosis. And so a normal median liver stiffness will be something around 4 kilopascals, and in patients with increased fibrosis, then it will be higher. The median liver stiffness in which we consider that a patient might be cirrhotic, and that depends on the underlying disease, it will be median liver stiffness about 12. In patients with NASH, for example, median liver stiffness about 12 are considered patients that have an F3, F4 fibrosis. And so that basically leads to additional changes in the management of the patients, including surveillance for HCC.
And which patients are you ordering FibroScans on typically?
We're now using FibroScans to determine the degree of hepatic fibrosis. So in any patient that comes with a diagnosis of an underlying liver condition, patients with NASH, patients with chronic hepatitis C or hepatitis B infection, they all get a FibroScan. All the patients with primary biliary cholangitis, anybody with an underlying chronic liver disease and that undergoes FibroScan testing.
And how would you screen this patient?
This patient will require, the recommendation is ultrasounds plus AFP, plus minus AFP every 6 months. Now, there's increased interest in patients with NASH. Most of those patients are obese, so in patients with higher BMIs, the sensitivity of the ultrasound falls down, And so there's an increased concern of missing HCC in these patients. So now there's the ASLD group is inclining more towards ordering triple phase CTs and MRIs on this group of patients just to increase detection of HCC among specifically patients with NASH and obesity.
Great,
Yeah.
great. So, so this patient, went on to have some imaging, and was found to have, solitary, lesion, which patient ultimately, has a solitary HCC here. There is, cirrhosis with evidence of portal hypertension. There was no evidence of extrahepatic disease. Patient ended up having a biopsy because it didn't, meet the exact criteria. But, going back here, so patient with the solitary HCC, measuring, about 3 centimeters or so in size, how would you manage this patient? Ramon, Dr. Menez, is this a patient that you would consider for resection?
Good morning, everybody. So, Ripple, traditionally for surgery, right, when we see a patient with a liver mass that we're looking to resect, there's 3 things that come into play: inflow to the liver, outflow to the liver, and the hepatic parenchyma. But that's for a general liver resection patient. When we deal with patients with underlying cirrhosis, which is usually the case for HCCs and all that, it's like I always say, this is playing golf in the wind. It's not just the regular golf game. So in these patients, it's not just the size and location of the tumor, but you got to look at the underlying liver function, usually with Child's classification. And again, that's not perfect. Sometimes you see a patient that is sold to you as a Child's Class A, but it's really a compensated Child's Class B. So then you do surgery and you pay the price afterwards, and you find out what I just told you. But so underlying liver function, whether that tumor has any vessel involvement, vascular invasion is usually a bad feature, whether it be a hepatic vein or a portal vein, radical or whatever. And then you're looking at whether the patient has portal hypertension. You got to look at all those things in these patients with HCC. In this patient, obviously, a transplant is probably the best option if you want to have a long-term result. I think this man at the age of 76, with all his other medical problems, AFib and all that, probably is not a priority on the transplant list, and it's just not realistic. So for me as a surgeon, I think surgery is an option. Mind you, I'm not so enthusiastic because of the underlying portal hypertension, and then all this CAP data that Maria just mentioned. It's kind of indicating that his liver, his cirrhosis, his liver fibrosis here is extreme, and so that there might be more incidence of complications afterwards. But none of these things is an absolute. So it's not the perfect candidate, but it's an option if nothing else is better.
For all the reasons that you mentioned, this is a sick, multiple comorbidities. He was, sent for transplant evaluation, but was not considered, from a medical comorbidity standpoint, nor did the patient actually want transplant. Dr. Kim, what would you do for this patient at your institution?
Yeah, I agree with everything that's been said. This patient, usually we don't have sharp cutoffs, but 70-year-old would be somebody that would, the upper limits of transplant at our institution, along with all the comorbidities. This is firmly a BCLC-A patient. So this is, 2.6 centimeters in size and has pretty good underlying liver function. So in that category, you want to do everything possible to give them a curative treatment. Certainly that includes transplant, resection. Ablation is an option here as well, but given the location and the age, we want to try and pick something that would be preserve the quality of life. And I think an ablation here, you could potentially cause pneumothorax, cause damage to the diaphragm, which would lead to pain in the shoulder and problems breathing, etc. So For us, given treatment migration that was described by Burrell out of the BCLC, we would favor a transarterial therapy, and then choosing between TACE and radioembolization, we prefer radioembolization, especially given the legacy data that was published in hepatology that was read out. Approaching near curative type responses, we would choose a radiation segmentectomy here and then observe the patient.
Yeah, so that was an approach that we chose to go with as well. So here's the patient's initial angiography here, and I'm going to show you a more selective angiography here. So as you can see here, there is some arterial portal shunting here. How would that change your management in terms of treating this patient with radiation segmentectomy?
I'd have to see the cone beam CT and see the enhancement pattern. You said there was portal hypertension, but the flow in the arterial portal shunt is still towards the liver. So if the cone beam CT can show accurate targeting of the tumor, this would actually not prevent me from proceeding with radiation segmentectomy.
Yeah, and then that's exactly what we did. I don't think I have a cone beam CT here to show you, but it wasn't one of those cases where you have portal venous shunting into your entire liver. You had still very nice concentration of the contrast in the actual tumor itself, despite this arterial portal shunting. So actually, I do have a cone beam there. So again, showed pretty nice uptake there. So this patient was treated with the radiation segmentectomy, and this is a 6-month follow-up scan. It was doing well. How do you follow these patients after local regional therapy?
For us, we follow all of our patients with MRI, and for our screening protocol, we do alternating ultrasound and MRI every 6 months, and then once they have a local regional therapy, usually with a radiation segmentectomy, we'll follow them in 6 weeks with labs, and then an MRI, and then for the first year every 3 months, and the year after that with stable disease 4 months.
So this patient, was actually lost to follow-up, so actually presented to the emergency room about 3 years later with abdominal pain. That arrow is off. The arrow is supposed to be pointing to portal vein tumor thrombus there. But nevertheless, the patient has this multifocal HCC now with portal vein tumor thrombus. There was also a couple enlarged portal caval lymph nodes. Still has preserved liver function, but has ECOG1. AFP is markedly elevated at this point. Obviously a BCLC stage C patient here. So how would you manage this patient? Dr. Morsa, you talked about these patients with portal vein tumor thrombus and advanced HCC. How would you manage this at your own institution?
Well, the first thing is we would still ask, even though there's some enlarged portocaval lymph nodes, those probably aren't going to be an issue for the patient, so we'd probably still ask our interventional colleagues whether there's an option here. However, this is a more typical systemic therapy patient. So the considerations here, he still has a preserved performance status, still has preserved liver function, so all of these would suggest that if he wants to take therapy, we could certainly offer it to him. I would ask GI to evaluate him for varices. That does introduce some time delay in some patients depending on how readily available endoscopy is, and certainly if somebody does require varices, and I don't want to speak for a gastroenterologist, but my experience is that tends to take a month or months sometimes to completely manage. So it can take certain systemic therapies off the table, but assuming he didn't have significant varices, this is probably somebody that would have been able to participate in the IMbrave 150 trial, and so atezolizumab plus bevacizumab would certainly be one of the considerations.
If there are varices that can be banded, can the patient still be treated with atezo-bev?
Yeah, in the IMbrave 150 trial, 10% of patients had previous treatment for their varices. So it can be done. What is the timing in terms of fully treating varices?
There are two different options when treating varices. One is just a medical therapy, and that can be initiated as soon as you identify the presence of varices. In the case of varices that have an increased risk of bleeding, and that's in patients, maybe not this patient with Child-Pugh A, but in patients with Child-Pugh B or C, patients with ascites, with a prior history of bleeding, then banding is the best option. Or patients with large varices with Redwell signs or high-risk bleeding stigmata on endoscopy. If you opt for the option of endoscopic banding, then you need to band until obliteration. So that means that you bring that patient as many times as you need to obliterate varices. That can take 3-4 months sometimes. But you can, if the patient doesn't have high-risk bleeding stigmata, someone like this with a Child-Pugh A, you just put him on a non-selective beta blocker.
You know, my concern with atezo-bev, and we've been trying to work it out in our institution, is the subset of the patients in the advanced stage with specifically portal vascular invasion. By nature of that disease, they're going to have increased portal pressures because you're occluding portal branches at some level. And so those patients, by the natural progression, have a 3 to 4 month median overall survival. And so our concern is that delaying those patients and our GI colleagues are excellent and they're extremely busy. But to get an endoscopy usually does take about a month or so. You're delaying precious time for initiation of therapy. And so if we feel that we can target with Y90, we will target. If not, we'll send them for external beam and really embrace combination therapies, which is what we're up here talking about, multidisciplinary care. And then I know there's not really data, but we'll start the ATEZ, hoping that the checkpoint inhibitor will have an effect, and then add, as long as everything is cleared, the bevacizumab on the back end, and just cross our fingers and hope for the best for the patient.
Yeah, I mean, that's actually a very similar approach that we follow at our own institution, and that's actually, where we went with this patient. So this patient was started on atezolizumab. We held the bevacizumab for the angiography as well as for endoscopy. And this is the patient's angiography. You want to comment on it, Dr. Kim? This is a patient that you'd be able to treat with Y90. Is there any way we're seeing,
It looks bad.
For those who are not used to seeing this imaging, we're seeing, this is massive hepatic arterial to portal venous shunting.
So this would kind of, scare me a little bit, but it is still flow towards the liver. We'd have to confirm with the cone beam CT or at least the SPECT CT to make sure that we can accurately target the portal vein tumor. If we can't, we would actually not do a radioembolization in that setting, and probably ask our radiation oncology colleagues to target the portal vein invasion, but the patient, regardless, would need systemic therapy, and I do think that checkpoint inhibitors really give the patients a really good shot. Unfortunately, the data that's read out, it's 30% or so have a response. Certainly the pembrolizumab is going up to 41%, but historic from the IMbrave 150, it's about 30-35%.
Yeah, so this patient actually, we did not deem him to be a good candidate for yttrium-90. There was not good targeting. I think the thought of external beam radiation is a very good idea. This was a patient that we did not do that. So the patient basically started him on bevacizumab, and he was already on atezolizumab at that point. Actually did really, really well on the combination therapy. As alpha-fetoprotein, this is a relatively recent patient, as more than cut in half. Follow-up imaging is actually still pending, but I'm just curious, Dr. Morse or anybody on the panel, what is your experience in terms of drops in AFP, and what are you seeing in terms of imaging response, with the tezo-bev combination?
So there's several considerations when people receive checkpoint blockade. If you have a drop in AFP like this, I would expect you're going to see some imaging change, even if it's a change in the vascularity of the tumor without a size change, and eventually you'll probably see a size change with that degree of AFP drop. However, there are patients that have what's called pseudoprogression. The lesions can actually look worse initially, but the numbers look better and they feel better. So those are individuals we would generally continue to treat.
Have you had any patients where they were not initially a candidate for local regional therapy? You treated them with the Tizo-Bev or some other systemic therapy, and they actually basically became a candidate for local regional therapy in the future?
That actually happens from time to time, and in fact, I discuss that with patients, that even if they aren't candidates currently, that we may integrate some type of local regional therapy as time goes on. I'm sort of expecting to do that as patients are living longer and longer with these combination therapies, that they'll develop individual lesions that don't seem to be responding, but the rest of the disease is, and that's definitely a good candidate for local regional response, as well as the one that has enough shrinkage to actually become a candidate for a more, let's say, curative approach with the local regional strategy.
Great. I think we'll move on to the next patient. This is a patient, a 78-year-old woman with a history of hepatitis C, has a 3.7 centimeter mass. A patient had a Child-Pugh B7. Imaging findings are suggestive of portal hypertension, good performance status, and low AFP. Let me ask first, Dr. Hernandez. A patient who has active hepatitis C and is found to have a probable hepatoma. Is that a patient that you would go ahead and treat for the hepatitis C?
Well, this patient specifically should be, he's 78. I might consider the hepatitis C therapy is restricted to patients with a expected survival longer than a year. In this patient, I might consider using antiviral therapy. There are medications that we can use in patients with Child-Pugh B that have a reduced risk of worsening disease. That's the problem with some of the antiviral agents that we have, that there might be an increased risk of hepatic decompensation while we're using them. So in patients with advanced disease, in patients with Child-Pugh B or C, if they're not transplant candidate, we prefer not to treat them just because of increased risk of worsening disease. And if obviously they decompensate or get worsening liver disease, they will not get the chance of liver transplantation. So patients would normally classify based also on MEL scores. So patients with MEL scores about 10, we're a little more concerned about treating hepatitis C in this group of patients.
I mean, this obviously isn't going to be your patient for systemic therapy, but I'm just curious, Dr. Morse, any experience in doing combination systemic therapy while you're treating an underlying infection like hepatitis C?
Dr. Hernandez brought up a good point. The older therapies, at least our perception for medical oncology, the older therapies were, it really wasn't safe to do it. They weren't as effective, and there was the concern about decompensation while we're also giving drugs that potentially can have effects on the liver. But now there's actually no concern in doing that. So we are routinely get hepatology involved to evaluate the patients for hepatitis C therapy.
You bring up a interesting point about the patient who might be on a liver transplant list. I'm just curious how if that affects their liver transplant at all, if they're with active Hep C at your institution. Any knowledge in that?
Well, having hepatitis C should not preclude a patient from being evaluated for liver transplantation. Now, the decision is to determine when to treat the hepatitis C infection. So in patients who you feel, like this patient with a Child-Pugh B7, in which you feel is safe to treat before transplantation, then you will start antiviral therapy prior to transplant. In patients who are Child-Pugh C, you might consider transplanting the patient and then treating afterwards. Now, with the medications that we have available, there are pretty high cure rates, and so you can actually delay hepatitis C treatment after transplant because of the concern that a patient who's Child-Pugh C will get worse while waiting for a liver transplantation.
Yes, especially with the implementation of the acuity circles, patients have been waiting quite a long time, especially HCC patients. They've been disadvantaged actually with the implementation of the acuity circles. So you used to be able to jump the line by actually transplanting Hep C livers and treating after the transplant the Hep C, because the antiretrovirals are so good at treating Hep C. But that's obviously a discussion to be had with the transplant team. But that's what has been happening across the country.
There's another issue with treating hepatitis C infection in patients like this. What happens is once you treat the infection, hepatic function will improve, and you will put these patients in what we call a purgatory MELD, where the MELD score will go down, but the patient will continue to have ascites and hepatic encephalopathy, and you will not be transplanting a patient with a MELD score of 10. So you're basically doing harm on patients like this because you're not going to give them the chance of transplantation, and they're going to be suffering with all this, the complications of a patient with decompensated liver disease. So that's another thing that we have into consideration when deciding about treating hepatitis C infection prior to transplant.
So this patient, went on to have, some imaging here, and you can see that this patient has about a 3.7 centimeter mass. The patient has evidence of portal hypertension as well. And again, the patient is a Child-Pugh B7. Dr. Jimenez, surgical options for this patient.
Yes. So as we mentioned before, Ripple, a couple of things here. Child's Class B, not ideal. And then that portal hypertension that's mentioned in there also, also not the best. But to be positive, I will tell you that this patient, as well as the prior patient, they have peripheral lesions. That lesion is like on the surface of the liver here. I think it's segment 5 or 6, not sure. I think that's segment 5. But it's almost exophytic. Half of the lesion seems like exophytic. And so they're very accessible from a surgical standpoint. That's a low-risk resection. You're not digging into the liver. You're not doing a lobectomy. You're not removing a lot of parenchyma. So if you had to do surgery here because there was nothing better, it can be done. The issues here with patients with cirrhosis is that the liver is not going to regenerate. So you can't have the same expectations that you have for non-cirrhotic liver. So the liver here is not going to regenerate. And then even taking a small amount of parenchyma can switch the patient into liver failure. So you want to try and do parenchymal sparing, non-anatomic resections as much as possible. And this lady here with that lesion there, a solitary lesion, I know she has another, her age and Child's B and portal hypertension is not ideal, but if you had to, you could.
Yeah, I think those were the same discussions that we had, regarding this patient, portal hypertension, older patient, Child-Pugh B7. Did send her for transplant evaluation, but she was really, we don't have exact age cutoff, but she was 78 and she wasn't deemed to be a good candidate. So I think we went through the different local regional options for a solitary lesion before this patient ended up having biopsy. So anyway, for this patient, we ended up treating this patient with chemoembolization. Although this is a few years ago, I think I'd probably do more selective Y90 today, but nevertheless. Patient was treated, did well. 3-month imaging demonstrated a complete response, but on 6-month imaging, it looks like there is a little, recurrence here. What would you do, Dr. Kim?
If the patient had chemoembolization beforehand, you've kind of occluded the vessels leading to that area, and so transarterial-based therapies, the efficacy decreases in that type of situation. So I wouldn't switch to a radioembolization, which I think a lot of people do. I think that's a mistake. You would either reattempt a chemoembolization, but I would actually scroll up and down. If the bowel is not close by, I would favor an ablation in this area. If not, if those are out of the picture, then certainly SBRT can be achieved. And I'm assuming there's no disease elsewhere.
Correct. Yeah. So those were some of the things that we're thinking as well. This was actually just adjacent to the gallbladder, and there was some bowel right next to it. Now, this was before we had. I think today in our practice we probably use IRE, as we can get away with treating these without injuring the adjacent organs. We didn't have that back then, and we didn't really think about I didn't think we could do this safely with other ablative modalities. So actually, this patient ended up having intraoperative, essentially microwave resection. I think even Dr. Jimenez can comment on this, very quickly because we are running over time here. But even with some of these patients with portal hypertension, it seems like you can do some of these microwave resections without encountering significant bleeding.
Yes, Ripple. I would have favored an ablation percutaneously, in all honesty, as Dr. Kim mentioned. But what I see here, that's an Aquamantis instrument there, isn't it? On the right-hand side?
I actually don't know what kind of instrument that is.
Okay, because that's just for maintaining hemostasis during the procedure. But what you mentioned, using the microwave-assisted ablation, which we call a surgically precoagulation, is excellent for maintaining hemostasis, Ripple, and doing the non-anatomic resection that I spoke about before. It maintains the field almost bloodless. And what you're doing basically is taking your microwave ablation antennas and going around the tumor, precoagulating before actually doing any cutting. Subsequently, once you finish the precoagulation, you can divide the liver literally with the scalpel, and not only does it not bleed, but it's literally all done. And your margin, let's say you're closing some areas, it's already ablated, so you get 2 for 1 in there.
That's great.
One of the worries initially was that when you divided the liver parenchyma after precoagulation with the scalpel, like I mentioned, you will get bile leaks and stuff like that. And it hasn't been the case at all. And so I'm a total advocate for this. Yes.
Yeah, so
that liver doesn't look too bad, I have to mention.
A patient did very well. The margins were free. I could actually see the beads from our chemoembolization. That was kind of cool. And I think that's something that we're learning. With some of the advanced technologies, patients doing well is getting surveillance imaging, and there's actually no evidence of recurrent disease 3 years after resection. And I think this is I think one of the studies that we happen to be participating in, but this is looking at systemic therapy after ablative or surgical curative intent. We'll see where this goes. Given the sake of time, I want to really thank the panel. Great panel, great discussion, great talk. I really want to thank you for joining us this morning. We ask that you complete the 3 questions on the right side of your screen if you're joining us virtually, or on your personal device if you're here in the room. And the general session starts at 9 a.m. See you there. Thank you so much.